Hello and welcome to the Under Pressure podcast. I'm Dr. Jonathan Sackyer and proud to be your host. We've got a great guest today, Mr. Ash Vasireddy, a British orthopaedic and trauma surgeon. Before introducing today's guest, though, it's important to specify that this podcast has been supported by My01, a Canadian medical device manufacturer. Please refer to the show notes for further information, and you can be in touch with us at underpressure@nextsense.com. That's underpressure, one word, at nxtsens.com. You can ask any questions that we shall endeavour to answer or recommend other topics you want to see us cover. So, to our guest, Ash serves as consultant orthopaedic and trauma surgeon at London's King's College Hospital, with special interest in adult and pediatric complex fractures of the pelvis, acetabulum, lower limb, and upper limb. I don't know that that leaves much else, frankly. He's also the ortho trauma lead and orthopedic trauma fellowship program director at King's, which is a level 1 major trauma centre here in London. Ash also works as a consultant and orthopedic trauma lead at the Cleveland Clinic, which is also in London, as well as in Cleveland, of course. And he's an honorary clinical senior lecturer at the London School of Medicine at Queen Mary University. He obtained his bachelor's degree in molecular medicine and medical degrees at London's Venerable Guy's Hospital, and then completed his specialist training largely in the London area. Ash enjoys traveling with his family. He's visited all the continents except Antarctica, and he enjoys sampling world cuisine, in particular fusion food. He's a martial arts aficionado and has competed in karate competitions at all levels, including international level, placing highly in competitions. So I better not upset him. And therefore, it's with great pleasure and immense gratitude that we welcome Mr. Ash Vasireddy to the Under Pressure podcast. Welcome, Ash.
Oh, very much. Thank you very much for those kind words, Jonathan. Uh, and to say, kind of, in terms of surgery, it excludes the spine, so I don't do any spinal surgery. And placing highly in karate competitions means I didn't get anything in the top three, but it's a polite way of saying that I did okay.
Well, my dear chap, my sort of measure of people's ability is what can I do? And I was recently talking to a chap who's done multiple marathons. I've tried training for one, and I guess I don't have the physiology or the commitment or whatever. So I've just got great respect for people who achieve things. Being a doctor is hard enough, right?
Yeah.
Achieving
Yeah.
seniority in your given area is a lot. And I just love meeting people who've got more than one string to their bow. And you've certainly got a lot. But in fact, let's start with something slightly off target. And I like to start gently. You're a Renaissance man, clearly. And I know that you've been a medical advisor to the media for a couple of productions, something called Critical for Sky TV and Holby City for the venerable BBC. And he also works as a doctor for the London Marathon and Swindon Town Football Club. And for our American listeners, that is proper football played with a ball and the feet. So come on, tell us some stories about these adventures and how you got into doing those things.
No. So I guess the first one is actually Holby City. That's medical drama. It's been around a long time with the BBC. And actually, I was doing a cardiothoracic junior resident job at the time, and the my kind of chief was actually one of the main advisors for that job. But part of it would involve him asking his junior residents and occasionally the senior residents to go on site at filming and give support to the production company themselves when they're filming it, to make sure everything was accurate, things were being sutured correctly, or at least in the correct manner, and making sure that the models they used were appropriate and people's hands were in the right places, and sterility was maintained in all the kind of operating room scenes. So it just involved a couple of trips to Elstree. Um, and so, interestingly, my then girlfriend, now wife, was actually following me on the job, and she ended up doing the same gig as well. So we used to go to Elstree and basically watch the production happen and just talk to the actors there. And I have to say, the actors were actually very, very receptive and very accurate with how they would deal with things and actually take on board what you said. And the props department that made all of the kind of fake torsos for open heart surgery and the fake hearts, lungs, etc. were incredible. And I was kind of semi wished actually we had something like that in our own training, so we could practice on things like that. So that was actually really interesting just to see that. It used to be an all day thing. There wasn't much in the way of kind of remuneration for it, but it was kind of different, interesting, and just actually a nice little de stressor from being a junior resident doing cardiothoracics. Critical. Critical was made by Jed Mercurio, who I did for the British audience. I'm sure you'll know him. He's the chap that made Line of Duty, the production and a writer of Line of Duty. He's a
Brilliant show.
doctor himself. Yeah, absolutely. He's an ex-doctor himself. So I'm not entirely sure what we were there for, but anyway. So that involved reading the script for one particular episode and just checking kind of the accuracy pertaining to operating room conversations and the overall storyline to just check that it was appropriate. That was a little more, well, it wasn't as exciting as going to the filming of the actual show. It's very much kind of doing it in the office and just reading through a script, which for an hour long show, I didn't appreciate how much script there was because it did take a long time to get through it and make a few edits here and there. And then I had to reread it again and then do all that. So that was interesting. The London Marathon. I haven't done the London Marathon for a little while, but actually, it's one of the first sporting things I did when I left university. So I had a job as a intern, so a house officer back in the old day, at Lewisham, and one of the uh, main doctors for the London Marathon, so one of the medical directors, was actually working at Lewisham at the time. So I just randomly decided to approach him and ask him if there are any opportunities for young interns who were really interested in sports medicine, etc., to take part. And yeah, he basically a couple of months later came back to me and said yes, and that's how it started. And I did it for quite a lot of years. I haven't done it for a good while now, but that was again interesting because it wasn't trauma per se, but actually you just saw a lot of people who were kind of hypothermic, hyperthermic, acute exacerbations of asthma, some people who were really unwell getting pulmonary edema, etc. And I was very much in kind of the minor injuries tent. They had a separate intensive care tent where kind of the really ill patients went. So we sent them there. And then I kind of just saw mostly the people who are either a bit too cold, a bit too hot, or had exacerbations of asthma. Swindon Town kind of happened at the early part of the last decade. I was working in Swindon as a junior resident in orthopedics now. So I'd passed through my cardiothoracic career and then went on to join orthopedics. And I was very much just about to start the orthopedic program, but had done a trust job, so like an independent job at Swindon, which again was a great hospital in itself, great place. I really enjoyed myself there. But again, one of the doctors or the orthopedic surgeons there was doing a lot of the sports surgery for the football club players when they got injured. So I asked him again if there's any opportunities to work. You can see that a lot of this is me asking people and people being kind enough to help me. So I asked him if there's any opportunities, and then he put me in touch with the club doctor. And so I was there for a year. So for pretty much most of that season, for all the home games, I used to go with the club doctor and accompany him to the home games and just basically support him as best I could. I was very much his kind of assistant for all of that. To be honest, there weren't any kind of horror injuries, a lot of soft tissue injuries, pretty much mainly the physios needed for that, and the odd player, especially on the kind of academy team, would have the odd injury, and we'd send them up to hospital or treat them at the club, depending on what it was. And so a variety of different things. Again, a lot of it just a little bit of luck in terms of the jobs I was in, but a lot of it just kind of I wanted to pursue different interests. I just asked people if they're willing to take a shot at me.
I would challenge you. I don't think it's luck. I think we make our luck. And I think for young people, young doctors who are listening, I mean, I could mirror some of your stories. It's about showing that little bit extra.
Yeah.
It's that little bit extra, and it's that desire. Can you show me? Can you learn me? Can I scrub into this case? Can I? Most people will really welcome that because if they're the kind of people who are doing something extra, they will recognize that quality in other people. I'll just tell you a quick funny story. I got onto an aeroplane once from the Puerto Rico, flying back to the mainland, actually to Baltimore, Maryland. I got on the plane And I was with my kids at the time, and I said, "Don't say anything, but sitting in the second row is Voldemort.
Ah,
Not Voldemort, no, no, Snape,
okay, okay, yeah, yeah,
Severus Snape."
yeah.
And it was the late and very lovely Alan Rickman. And my kids were like, "Ugh." And as it happened, my seat was next to him.
Okay,
And I sat and chatted with him, and I said, why are you going to Baltimore? And he said he was making a made for TV movie called Something the Lord Made.
okay.
And it's the story of Alfred Blaylock, the cardiothoracic surgeon who actually was a little bit of a naughty boy. Um, why is it they always cast British actors to play villains in
Oh, it's
American?
a long-standing thing, isn't it? Don't know why.
But he was working on the script and he played Alfred Blaylock. And when I said, "Oh, I was a surgeon," that was it. And we became fast friends. And I had the privilege of knowing him. And I looked at the script and gave him some pointers
Oh,
and
wow.
introduced him to some friends who were cardiac surgeons. And I, like you, I found that people they want to do the best job they can, and
Mm.
they use the information we give. Well, another passion of mine is flying,
Yeah.
and I want to get on to something you've done. You're coordinating, and I do this because your background is important, and the perspectives people have about the topics we're going to discuss further into this conversation are coloured by the kind of life you've lived. So
Mm.
you've been involved in coordinating and advancing trauma care in some cool ways. And I'm a keen aviator myself, so kudos to you. You're acting flight surgeon for the United States Marine Corps Air Station in Miramar, California. That's Top Gun for those who didn't know. And you were lead also for major incidents for London's air ambulance service. You've been heavily involved in that space, and you've been a lecturer at the Institute for Pre-Hospital Care. What got you into that line of work and your interests and, I guess, the joys and challenges of airborne missions in London's very crowded airspace and very busy city? It's not like, American cities where there are huge wide roads that you
Mm.
can drop an
Yeah,
ambulance into. So tell
yeah.
us a little bit about that.
So, I mean, just to roll back, I mean, the whole American Marine Corps thing was an interesting story. So, back when I was at medical school, and even before that, I always had an intention to join the military. It's not an intention my parents were particularly fond of, but it's always something that really appealed to me. So, I'd done a lot of military related stuff while I was at medical school. And so that's how that came about. Interestingly, it was the year after 9/11, and as part of medical school, you are given the opportunity to go abroad and do something called a medical elective, where you can go experience medicine in another country, do something really interesting. A lot of my friends went to Africa, went to kind of Polynesia and do kind of interesting work there. Some went to India. Others went to, around the world, basically everywhere. Some had an extended holiday on top of that as well, which is all good fun. It was in the process of doing something with NASA, which a friend of mine had done 2 years before, and I kind of liked the idea of what I heard about. But following 9/11, all those programs shut down, as you can imagine,
Yeah.
for their own American nationals, let alone international people from other countries. Because even if you were British, and even despite kind of a very good relationship with both countries at the time, so I thought, well, I don't necessarily want to do another hospital event because I kind of had already arranged something in California for that anyway. So I thought, well, I guess I could switch from aerospace medicine to aviation medicine. So then I literally, again, managed to get the phone number and email for the kind of the officer in charge of the base at Miramar for the Marines. And at that time, I was, as I say, doing stuff with the British Army at a kind of university officer training corps level. And so I had a kind of low lying rank in that, and I was part of that organization. So it was very easy for me to then call him up and email him out of the blue and just asked him if there's an opportunity for me to come over to the USA. And they supported me with that at the Marine Corps. And so got my blessings from the commanding officer in my British Army unit. And so went there for basically just over a month and went there as an acting flight surgeon. and kind of day-to-day stuff. In each week I was there, I was attached to a different squadron, flying around with different units, practicing various rescues. Also would work on in their emergency department, which they had their own emergency department on the kind of main station, and it also had like an urgent care center as well. So did all that work, and so just had a really great fun time. And I love Americans because it's actually I've had such a fun time, and they were really hospitable to me because I kind of at that time I didn't even know how to drive because I'd kind of was studying in London, hadn't got around to my license. Little did I know how painful it was to get around America without a car. And I remember I even managed to do my ACLS when I was there. They organized it for me. It was all free for me because I was obviously attached to them in the military. And but I remember having to wake up at 4:30 in the morning every day for about 3-4 days and get 3 buses to get to the University of San Diego Hospital to
I
do
used
that.
to work there, Ash.
Oh, did you? Oh,
Yeah,
wow,
yeah.
that's amazing. Yeah, it was a great site, and then had to get 3 buses back to the back to the air station, and it's all right. I still made it in by 6, and then did all that. And yeah, just really looked after me. They took me to baseball games and football games, this American football now, football games every weekend. And then got to do like an audit while I was there. One of the regrets I have is they asked me to come with them to Las Vegas on one of the pilots' bachelor parties. And I, to this day, regret not saying yes. And the reason I didn't say yes is because the commanding officer for the medical aspect of the air station asked me to do an audit for him on the A&E department, and I was like, well, he's asked. I don't really know how to say no, and it's only for his grace that I'm actually even allowed to be there. So I was like, I'd
I
like to
think
think
you
I did
made
the
a
right
very
thing.
good decision.
Yeah, I made the right decision.
I used to hang out with American aviators at some of the big air shows, and they'll have like little separate parties. I have
Yeah.
to say that the RAF parties were always bloody good, but
Mm,
I have to say that the United States Marine Corps parties were
mm,
fun.
yeah,
I
yeah, yeah.
think your liver
I
is probably grateful. But you got into
no, quite.
involved in the air ambulance
Yeah,
services in London.
yeah. So that was a separate thing. So I was doing my another junior resident job in emergency medicine in Essex. And I was basically every week we'd have a different speaker in an educational session. And one of the speakers was a chap called Gareth Davies, who's a very inspirational figure to a lot of us here in the UK, who's looked done a lot of pre-hospital medicine. He gave a talk about pre-hospital care and talked about London's air ambulance, and I was totally transfixed with that. I'd always been interested in trauma, and the talk he gave talked about how to do pre-hospital care where you're doing effectively kind of very, very old school kind of medicine as it was by the roadside, really taking a good history, understanding how patients got injured, understanding what their injuries were and what treatment they needed, and then kind of beginning that resuscitation and their treatment cycle at the roadside. Inspired by that, the difficulty being that I wasn't an emergency medicine trainee, and neither did I want to do that, or did I want to do anesthesia. So I kind of just pushed my way and managed to do training in anesthesia, intensive care, emergency medicine, and then managed to then get appointed back in 2013 into that job at London's Air Ambulance, and then have been with them for a long time, and now continue on with a academic role with them. And then I still work clinically in pre-hospital care, but for Essex and Herts Air Ambulance, which is the local air ambulance organization that supports the region where I actually live.
Right.
So I wanted to do that. So being able to do all of that. In terms of the flying is fantastic. Clearly, I don't fly at all. I just sit in the back and get flown about to different places. But it's amazing to watch the pilots. I've got absolute admiration and total faith in our pilots of the helicopter. And in London and in Essex and Herts, they can pretty much land wherever they want. When they're airborne on a mission, they take precedence of all other call signs and aircraft in the air. We've seen, as we've flown by different airports, we've seen different aircraft try to land and then get told to kind of lift off again and just go back up and go around. And it's interesting just to see that and how they manage landing in very, very congested areas, but obviously with maintaining safety all the time, making sure that no one else gets hurt, we
Yeah.
don't get hurt, etc. So it's just amazing to see that, and amazing to see how passionate they are about their flying.
Yeah, I'm a fixed wing pilot,
Mm,
and we always take the mickey out of helicopters. You know, they don't fly, they're just so ugly. The earth repels them, or it's 10,000 rivets flying in close formation and all that kind of stuff. But you're absolutely right. Kudos to them. It's an immense task. So you mentioned the United States, and just give us a brief overview because you did an orthopedic trauma traveling fellowship at Shock Trauma in Baltimore, very famous place.
Yeah.
Harborview Medical Center in Seattle, and so on and so forth, Mass General. Tell us what you saw in American trauma that was different to the UK system of delivering trauma care, and what you've, I guess, brought back and deployed in your work.
Yeah. I mean, so there are a couple of aspects. I went to Boston and did a short, like, kind of visitation there at Massachusetts General, just to see how the system operated, and it just gave me a very kind of very basic understanding of how orthopedic trauma works there. I mean, one of the biggest differences in general between the UK and America is orthopedic trauma as its own specialty. It's in America, throughout America, it's recognized as its own specialty. You know, for example, like hip replacements and hip surgeons are recognized as their own subspecialty, knee surgeons, their own thing, upper limb surgeons, etc. In the UK, there are orthopedic trauma surgeons who do full time trauma, but it's not the whole separation of them as subspecialty. It's only now, more recently, beginning to happen. When I originally went a while back, it was much more mature in the USA. So it was interesting to see that dynamic and see this group of surgeons who are trauma specialists operate on upper limbs, lower limbs, and pelvis and acetabulum. Whereas in this country, generally, if you were to ask any non-orthopedic surgeon who does shoulder fracture management, they would say a shoulder surgeon. Who does a knee fracture management, they would say a knee surgeon. But it's amazing to see this group just doing all of it. And that's how, kind of, I thought, in terms of my training, I want to be able to have that perspective. So I did that. And also, they didn't do any elective operating. They just did trauma. And that's always what I wanted to do, just pure trauma and no elective. So I was just trying to copy that. I went to Cleveland and basically spent some time with Professor Heather Villiers, who's a eminent orthopedic trauma surgeon, published widely, ex-president of the Orthopaedic Trauma Association, to understand about early appropriate care, which looks at timing of surgery after patients have injured. Like, what kind of timelines do you need to fix their spine, their pelvis, their acetabulum, their femur, in order to get them optimally recovered? And I went there specifically for that target. And then I went to Harborview to learn specific operative skills, because Harborview is regarded around the world as, kind of an amazing institution. They do
Yeah.
amazing technical surgery, and I really wanted to learn that from them about how to put complex fractures back together. And I got some amazing tips that I use day to day now. I learned about different pieces of kit that they use to help them do that. I use all of that now. And shock trauma, again, a really well known institution. A friend of mine, or actually someone who trained me in my anesthesia, actually had worked at shock trauma, done like an anesthesia trauma fellowship, and she helped me get me through the door, because shock trauma is very difficult to get in through the door if you're international, even if you just want to go see the place. But I managed to get through that door with her help. And then I spent some time there and actually built some connections, research connections with shock trauma. And, currently in the process of trying to sort out a international RCT trial in open fracture management. But again, went there to learn about operative management and kind of how they treat their complex fractures. So learned a lot of techniques again, which I now try and teach everyone else that passes through our institution here at King's.
Mm.
How is it different? I guess that, apart from the logistics in terms of, the different groups of trauma surgeons, etc., one of the biggest things I actually interestingly found, I imagined when I went over there, I would see operating rooms being super efficiently used, like, time is money kind of thing. So patient goes in, operation's done, patient gets whisked out, next patient comes in. But it was like as bad as as bad as I've seen anywhere else. Like, there's massive lulls between cases, and I was really surprised. And I thought, well, how are they getting all their cases done? Because there's massive lulls. And then you kind of realize that all the hospitals got like 25, 30 theaters. They've got huge, immense theater numbers and are able to use that, which is something we just, in my institution, and I pretty much probably can say in most hospitals here in the UK, just don't have access to that
To that
number of
many
theaters.
theatres. So
No, and that many
yeah,
staff to run them.
Yeah, and actually, it struck me because I worked in the States for half
Yeah,
my
yeah,
career that the UK was actually more efficient, but
yeah,
they've just got so many more facilities.
yeah, yeah,
But
yeah,
there we go. So I want to move on a little bit. You've written about mobile apps for patient trauma education.
yeah.
Tell us about that and how you see such tools mitigating risk with complications like infections, compartment syndrome, and others.
So that is something that I is a project that I work with Professor Heather Villiers from Cleveland. She had set up this app to use for patients, and then we in the UK, with King's as the UK site, started to tell patients about this app, and it was really to give them information about their injuries, general advice about how to manage at home once they were discharged, again general advice about physiotherapy and what kind of exercise they can begin to do. Because the biggest problem we found here in the UK, and it's, to be honest, it's a big problem everywhere for trauma patients, is education and kind of how to give them information. And because the issue is, if you give it to them all at once while they're in hospital, clearly they won't remember all of it. It's a little too intimidating to do it all at once. So we thought the mobile app would present a much more useful way of doing it, so patients could do it in their own time, in their own convenience. We found that actually it did get downloaded a huge number of times across the world, and we were doing it in North America, some in the Middle East, and then very few in the UK, in Europe. So it was being used quite often. Patients did like it. It was obviously a very cheap application to run because it didn't need much servicing, and again just provided that kind of information on what patients had to look out for. How did it help in terms of mitigating risk against infection and compartment syndrome? I guess it'd be difficult to quantify that, other than to say that it just gave patients more information, so it allowed them to be more empowered to contact their provider or their clinical team if they had any specific concerns. Because all patients generally, when they leave, are given a contact number to call and speak to someone if they need assistance with anything. And obviously, if there's something very urgent, they can just present to the emergency department themselves. So it just hopefully gave them that knowledge of what to look out for.
Well, the whole concept of patient education, empowering patients, making them part of the decision, their management, it stops them just being the target of treatment. They're involved in the totality of the treatment.
Yeah,
I'm a
absolutely.
big fan of that. So I note that a few of your activities include discussion on whether or not to do peripheral nerve blocks in tibial shaft fracture.
Yeah.
Um, I didn't break my tibia, but I did have an ankle fracture years ago. And I remember when the doctor came around, looking for compartment syndrome and was asking me, does it hurt more or less? I was actually having an I was a medical student at the time,
No, okay.
and I was having an internal dialogue that if he asked me one more time, I'm going to thump him. Because all I knew was it bloody hurt,
Yeah,
and I
yeah.
wanted a block because of the pain. And I also saw reference to webinars on the management of tibial and femoral shaft fractures. Can you talk to us about nerve blocks in the context of, and your work in this on the context of compartment syndrome?
Yeah, so as you know, compartment syndrome is a syndrome in which you have raised pressure within a closed osteofascial compartment. And then the consequence of that is it effectively reduces the blood supply to the structures within it, affecting the nerves and then eventually affecting the muscles, etc. And it doesn't respond to standard pain relief. It becomes worse and worsening pain. The issue with this is, and the problem a lot of people have, is diagnosing it even in patients who are awake. And the bigger issue that we all have a slight apprehension with is its use in surgery, because we're worried that if we do complex surgery for someone and then they have a nerve block, if they were to suffer a post operative compartment syndrome, would that be easily diagnosed because you've effectively numbed their nerve so they wouldn't feel pain? And so there are massive variations in opinion about this. There are definitely many surgeons who are happy with the anesthetist giving a nerve block, and they will have the kind of team post-operatively go review the patient clinically and see how they are, and examine them. The argument being from the anesthetic side is they can do the nerve block with a kind of a certain titrated dose, which means that it will afford good pain relief, but if there is compartment syndrome, the pain from that will break through that local anesthetic that's been infiltrated, and so it will not mask the symptoms of compartment syndrome. That's one opinion. The other spectrum of that opinion is that actually the nerve block will mask all the symptoms. You'll not know they had compartment syndrome, and they will not get diagnosed, and they will suffer all the consequences of miscompartment syndrome, which, if it's in the lower leg involving the tibia, that is quite horrendous and associated with lots of complications, and clearly compensation as well on a separate issue. So it's always been slightly difficult. What we're trying to do at the moment, or what's happened up until now, is people have just gone with either their own preference as individuals, or departments have had their own departmental policy, or some hospitals have a hospital-wide policy. Well, what's going to hopefully happen over the next year is that our governing body, so the British Orthopaedic Association, in conjunction with the Anaesthetic Association, will basically come out with a consensus statement of what one can do and how it should then be enacted. And our British Orthopaedic Association has actually been really good about providing standards of care protocols for different injuries and different treatment options. So I've got full faith in this coming out. What my gut feeling is, it'll say along the lines of actually nerve blocks are okay, provided they're applied in this kind of situation and you have the appropriate follow up in the post-operative setting on the ward or in recovery where patients are examined, etc. And then if there's concerns, you then do this, this, and this. I see it that I suspect that's what will happen. In the USA, uh, although I've obviously not got great experience of it, I'm aware of they have much more of a traffic-like system where if you have this constellation of injuries and it's a red traffic light, it means you do not have a nerve block. If you have this constellation of injuries, it gives you an amber traffic light, and you could have a nerve block depending on the surgeon patient anesthetist discussion. And then if you're green and have that constellation of injuries, you can definitely have a nerve block. So I think that's where the US is. I think where ours is probably going to be slightly more binary of you can either have it or you can't, and then it depends on this constellation. But we try to get, you know, a lot of kind of decisions about this made between the surgeon and the anaesthetist before the patient comes to theatre, so that it's that decision is done. Personally, I've been on a little bit of a journey to do this. So initially, I just copied everyone else and I said no nerve block, thank you very much, if the anaesthetist offered. And then these days, though, I'm much happier. I will let the anaesthetist, if they're happy and they can give an appropriate dose that won't mask the symptoms, then kind of I'm okay with that nerve block happening, and then we'll just have the on-call team go see the patient post-operatively and examine them.
So you've got a rational approach to this, and you've presented the evidence, you've presented the different perspectives. There are professional medical societies giving guidelines here and in the United States. Given the data as I understand it, which is that it actually doesn't interfere, and the pain, frankly, isn't a good indicator of whether or not neither are the P's that I learned about. It shows how darn ancient these were. They were around when I was
Yeah,
learning my surgery, and that they're frankly not that useful as clinical indicators. And given that, a patient's experience, pain is horrible.
yeah.
It's what people think about. It's why they go to hospital. I'm in pain. Why hasn't peripheral nerve block been more widely adopted?
I think it's just everyone's worried about the miscompartment syndrome. I think that's the
But
biggest issue.
even
Mm,
with the data, the
yeah,
pain isn't a good indicator.
yeah. I think fundamentally we're all kind of semi used to our routine of care. And this
Hmm.
is how the routine of care has been, which is that we've taken a lot of time to evolve into accepting nerve blocks for managing pain. And nerve blocks and regional blockade in themselves, and the ability to do really accurate regional blockade has also been evolving over time. And I think now is definitely, I remember things now are definitely different than how things were when I started as a consultant, good
Yeah,
6
sure.
years ago. So even in this short period itself is different. I remember when I was a resident, no one was having nerve blocks for anything.
Yeah.
Yeah, especially for fracture management, it just wasn't a done thing. But now it's just changing. So I think things are changing for the better. And I think, kind of consensus statements from our professional bodies will make a big fundamental change when
Yeah.
that happens.
But you're right. I mean, listen, the pace of change in medicine is inertia bound.
Mm,
That isn't necessarily a bad thing because it means that we review new evidence very cautiously and very carefully. However, I think and I'm just not talking about compartment syndrome here, just generally, I think we need to be a little bit more energetic in the way we look at new ideas.
yeah.
And you look at everything from Barry Marshall and Helicobacter pylori to, Hodgkin, for goodness sake, he kicked out of his hospital for having the audacity to suggest what he suggested, and many, many other innovations. I think we could do a better job at saying, hang on a second, we've been doing it this way for a long time. Maybe this is a better way of doing it. So, in your experience dealing with a range of trauma, in my experience, trauma and alcohol tends to be associated. So you
Yeah.
then have the complexity of dealing with a patient, or they've got multi-trauma and they've got
Oh,
lower
yeah.
levels of consciousness because they've had a head injury, or they're pediatric or they're geriatric, and you've got confusion, Lord knows what else going on. What are the challenges faced in making this complex diagnosis of compartment syndrome in these complex patients, and how can these be managed effectively?
Yes. I mean, I think compartment syndrome generally is still regarded as a clinical diagnosis. You take a history, examine the patient, you make a diagnosis. That's usually the end of it. The biggest problem we have, as you quite rightly point out, there is a issue with the use of drugs in patients, alcohol and other drugs. Patients may have significant head injuries, may have other injuries elsewhere, they're polytraumatized, etc. Children, and then very elderly patients. So all these groups, it's not quite so easy. So I think, your 20-year-old, 25-year-old with an isolated mid-shaft tibia fracture, where you're concerned about compartment syndrome, who's got no other injuries, and this injury was sustained playing football, would be your standard textbook case where you can take a nice history, you can examine them, and then you could probably come to a good clinical diagnosis and then monitor them or treat them as required. But all these other groups I've mentioned, use of drugs, etc., you need something a bit more robust to help you with the diagnosis. And so a lot of people then talk about measuring compartment pressures. And so, how do you do it? So they're either kind of manufacture devices that you can use to measure them, or you can kind of set your own up. And so in the kind of in the within the hospital, if you set your own up, how does that work? And so you would basically take someone to the theater or into the anesthetic room, or you would have the operating department practitioner, so someone like an anesthesiologist or a practitioner of that sort, to set up a central venous pressure line and arterial line. And then you just connect that to a needle that you would then put ideally within 5 centimeters of the fracture in the relevant compartments, and then look at the pressure. And then you either have obviously your kind of threshold value of over 30 millimeters mercury, or your delta P, which is the difference in the diastolic. And then if you're in that ballpark, then you use that to diagnose your compartment syndrome. And so the delta P being the commonest one that everyone uses, the difference from the diastolic.
Yeah.
Um, and so that's the one that everyone would use. And that's how you do it in this group of patients. The problem is it's always a one-off reading. You can't really leave that needle lying around. You kind of have to take it out. I don't really know that any of us would want to repeatedly keep doing it. Um, and so that's where that problem comes in. So how do you kind of keep an eye on these patients repeatedly? Like you may have said, there's no compartment syndrome on that one-off visit that you've just done, but when you go to see them like 4 hours later, 5 hours later, and everyone else is still concerned, how do you know that the figure you just measured 4 or 5 hours ago is still the same figure now? And so, yeah, there is a kind of slight gap there about how you manage specifically in terms of watching the evolution of this, because it is an evolving condition and it can be. And so I don't know that we have any great answers other than
Well,
how much continued monitoring.
hence the genesis of the concept of
Yeah,
continuous
exactly.
compartment syndrome measuring the pressure over 20, 18 hours or so, and
Yeah,
just
yeah.
seeing what the trend is.
Yes.
Again, going back to the aviation thing, those pilots that you're so impressed with, I've been flying for decades, and the planes that I fly have multiple ways of telling me how much fuel there is on board.
Mm,
And if someone said, well, we've come up with a new way of measuring fuel left in the tanks and fuel flow and projected flight endurance, bring it on, bring
mm.
it on, because running out of fuel, that's never a good thing. So
Yeah.
any kind of measurement that gives you certainty as to what's going on has got to be a good thing. Anyway, I want to go back to something else that you said.
Mm.
You mentioned recompense. I'm trying to remember what word you used. In regards to a misdiagnosis, there could be
Or compensation.
compensation.
Yeah, yeah.
The lovely thing about being British for our American friends, Ash, we are masters of understatement. It's really quite delicious, and I guess that's the big difference. One of the big
I think
differences.
in America they use compensation to talk about salary, don't they? We use it in a
Yeah,
quite
well,
a different
the
way.
one that always got me when I moved over there, and someone told me that I was going to get a citation. I was very excited. I thought that's a
Oh
traffic
no, yeah, yeah,
fine.
no, no, yeah, yeah,
So, you don't want to get a
yeah,
citation.
yeah,
So in the United States, there have been some massive payouts in the
yeah.
wake of both compartment syndrome that was missed and alternatively, people who had unnecessary fasciotomies
Mm,
and ended up with extended hospitalizations, skin grafts, getting Lord knows what complications of being stuck in a darn hospital. You've written about the medical, and there've actually been some pretty sizable payments here. The biggest
yes.
in America I came across was $111 million
Wow.
in a young man who didn't die nor lose his leg, but it was a misdiagnosis. Apparently, it bankrupted, I believe, 13 doctors. I must fact check that, but I believe
Mm,
it 111 million. Anyway, that was in Minnesota. I know
right.
that you've written about the medico-legal
Mm,
consequences of this. So can you discuss some of the challenges and how medical professionals can protect themselves from potential negligence claims for missing a case or doing what turns out to be an unnecessary fasciotomy with downstream consequences that I've mentioned? Now, obviously, just have to say this, the goal has to be doing the best,
yeah,
delivering the best possible care for the patient,
yeah.
being kind and being communicative.
Mm,
Because I was always taught, look after the patient to the best of your capabilities, and if you can't do it, bring someone in who can, but be kind and communicate. The floor is yours, Ash.
no. Absolutely, I totally agree with what you say. In terms of the cases in the UK, I'll be honest, I don't know many cases where anyone has been taken to task about over treatment, so doing unnecessary fasciotomies. There have been plenty about miscompartment syndrome. And the typical scenario, some of which I've dealt with personally as a medical expert witness, include ones where people have had nerve blocks for compartment syndrome. Or sorry, let's have had nerve blocks for surgery, and then had miscompartment syndrome following said surgery. And in that group, the issue, for example, is usually the patients uh, are not necessarily managed on an appropriate ward where the staff are trained to manage it. Some hospitals have a very developed and a very mature and a really well set out observation chart purely for the nurses to check for compartment syndrome and go through all the examinations they're meant to do. Other hospitals who are pretty much doing the same thing do not have that kind of observations chart. And so where that doesn't exist, you can imagine the accuracy of post-op checks are not as good. And so that problem happens. There's a lot, and I'm sure all our British listeners will recognize a lot of our orthopedic patients may be on a ward with a lot of general surgery patients or ENT patients, and the nurses there necessarily are not specific orthopedic nurses, so they may not be fully aware of compartment syndrome to the same degree. Obviously, I'm talking about the kind of wards support a lot. It's not necessarily their issue. The on-call team, who sometimes we ask to go see the patient, may be busy, and so you can imagine things get delayed when coming to check these patients. And so a lot of it is kind of to do with the systems. It's not usually And when these claims get settled or get taken further, the issue gets bogged down in either the people end up saying that in this, in the cases I've dealt with in the UK, people end up saying, and it's not it's usually the anesthetic expert, not really the orthopedic expert, because it's not our bit to comment on, but usually the anesthesia experts usually say something lines of you need to be really careful about doing nerve blocks if you don't know what the post-op monitoring is going to be and if you're not certain how it's going to be done. And that is a real problem, and that's a really interesting thing to look at. But clearly it means that you need to really think about the journey for the patient after the surgery and the first few days, not just think about what is the best thing to do
in the
during the
operating
surgery.
theatre. Yeah,
So, I mean, if you can put something in that will last 6, 8 hours, then that's probably kind of really useful, because at least the on-call team can check for a very short period of time, remembering that the patient will probably be in the theatre complex for about 4 of those hours. So it'll, wear off pretty quickly. But the problem is, if you give something that lasts much longer, it then becomes difficult to separate out weakness from compartment syndrome from weakness from the nerve block. And so that's the issue that's usually the problem. And I really think there are certain hospitals here in the UK that are really, where colleagues of mine work, where they're really good with their post-op compartment monitoring after surgery. I've seen observations chart from their hospitals which are really detailed, and stuff that we don't have in other hospitals. And I think really, if we all get on the same page of how post-op monitoring is for these patients, I think that will actually help negate some of these issues. And then if we had an objective measure as well, that will just help add to that layer of kind of diagnosis and support the patient requires.
interesting. So, can you share any notable case studies from your practice that highlights the complexities of managing compartment
Yeah,
syndrome
yeah.
and
So the
lessons learned?
so the one I was thinking about in particular was a patient who had a very severe tibial plateau fracture, so a Schatzker 6, which is a very severe bicondylar fracture of the tibia. And that patient, usually when you treat those, you treat them traditionally with plates and screws, so that's fine. So patient went to theatre, they did a nerve block, and then they treated it with plates and screws. Patient went back to a non-orthopedic ward. There was no compartment syndrome specific uh, observations charts for any of the nursing staff to use. The post-op notes that the surgeon writes commented about, check for compartment syndrome, but there was no detail as to how exactly should one check for compartment syndrome, how often should someone check for compartment syndrome. So again, that's an interesting thing for me. So I see these cases and I think, oh goodness, okay, maybe I need to evolve my own practice, because clearly it's a problem, it's become a problem for someone. I need to learn from this. So so I write down things about how frequently it ought to be done and how typically to do it. And then that patient also was very keen on going home. They weren't sure about how long the block would last. And so you can imagine now, we're now at 10, 12 hours post op. So the following day, patient still has a lot of weakness, no pain, but just a lot of weakness, can't move their toes, can't move their ankle. And it kept getting attributed to the nerve block. Okay, so we're now like, so time goes on. So it's now 18 hours, 24 hours. So we're now a full day out from the surgery and the nerve block, and he's still got the same weakness, not much pain, just weakness, can't really do much, can't really feel anything either, again attributed to the nerve block. And so in this case as well, no one senior was able to review the patient. So you can see where this is heading, right? It's only
Yeah,
the junior staff and non-orthopedic nurses seeing this patient. And the patient was thinking they were getting on fine. But everyone kept telling the patient, just stick around, we want someone senior to see you. And then eventually the patient ended up being, he ended up self-discharging, because he just fed up, like he was doing fine self-discharging, so went home. And so overnight at home, suddenly he started developing increasing pain at home. And then so his wife brought him back into hospital the following day. The problem is they didn't come back to the hospital where they were treated. They went to a sister hospital, a distance away, because they did not live near the treating hospital. They lived near the other one. So they went to the emergency department in the other hospital, who then, it took a while for them to diagnose and then put them in an ambulance and transfer them back to the treating hospital for this intervention. And then, kind of, once they got to the treating hospital the following day, then everything happened really quickly. But I think clearly at some point at the back end of when he had self-discharged or overnight, clearly when he started getting the pain is when the compartment syndrome happened. But then it'd been over 12, 16 hours before he had fasciotomies. And at that point, it's a really sad story because clearly a lot of the muscle had died. It was quite significant, and he ended up needing an amputation.
Jesus.
So that's that's the worst kind of outcome that you can have. And so with that, clearly, it becomes really difficult to defend that issue. A lot of people would argue, a lot of people, I think many surgeons would suggest that actually, I'm not necessarily sure about that specific case, but a lot of surgeons would suggest that in those patients, if they get compartment syndrome after the operation, their injury was severe enough that they would have got compartment syndrome anyway, and maybe the surgery didn't increase the risk of it. And I can see their point. I think nonetheless, though, it all comes down to diagnosis. It all comes down to really close follow up after the surgery and making sure that you don't miss it, because clearly the injury needs to be managed, and these injuries need to be surgically managed with whatever device you care to use. But you still need to keep an eye and make sure those patients don't develop any late complications.
Can I suggest to you yet another tiresome aviation analogy?
Yeah, yeah.
When I learned to fly, I learned a protocol that when I started learning medicine and doing surgery, because the flying came before, uh, was stay ahead of the aeroplane and constantly be asking yourself, what's the worst thing that could happen now? And
Mm,
what would I do about it? And, you're flying along at altitude, everything's going along great. But when something bad happens, it happens fast and it can be very confusing and very baffling. And if you weren't expecting it, it catches you unawares. And I would suggest, isn't one of the issues here constantly asking yourself, is compartment syndrome a possibility?
mm,
Is compartment syndrome a possibility now? Now, now, now. Um, One of your colleagues who I spoke to, different hospital,
mm,
by that I mean another orthopedic trauma surgeon, said that he suspected that it was underdiagnosed because he said, we'll see patients who'll come back to clinic and they've got their toes a little bit hammered.
mm,
And he said, we probably missed a bit of compartment syndrome. Of course, here it was a wretched outcome, and of course, it can be tragic, it can be fatal.
mm.
People can die from this. Uh, there's a famous reporter, Miles O'Brien, who lost his arm to compartment syndrome in the United States. A camera case fell on his arm.
Yeah, yeah, yeah.
Um, missed case. So isn't it awareness that people need to be asking
Mhm.
themselves a little bit more?
Yeah. No, no, I completely agree. I think I've learned a lot of lessons from my air ambulance work, because
Yeah,
if you look at air ambulances now, a lot of the clinical stuff that happens in terms of checklists, protocols, etc., are all based off how aviation
yeah,
has evolved over time. And clearly, aviation, I can't remember which Matthew Said book it was that I read to learn about the aviation issues, but it's obviously one of them, maybe black box thinking, I think. But there's a lot of lessons that aviation has had to go through, painful lessons over many, many years and many lives, to basically become the very safe kind of specialty that it is. And so in air ambulance medicine, we have lots of protocols. So if someone is being transported in the aircraft and we note their oxygen saturation's going down, we have an SOP and checklist to quickly go through everything rapidly as to what you need to check to correct it. And
yeah.
also we have lots of pre-flight checks for our patients before we lift from the ground, to check that what are we going to do if patient vomits, if the airway gets compromised, if how are we going to signal to each other what the problem is in such a noisy environment, about what to do with this. The problem we have, especially, is that because of our shared radio system, if we start talking to each other, doctor or paramedic in the aircraft, it gets in the way of the pilot and the co pilot speaking with air traffic control, especially if they're navigating a heavy airspace like London. And then sometimes they need to shut us off so we can just speak to ourselves in the back. So, doctor, paramedic. But if they shut us off,
You can't
we
speak to
don't know what's
them.
happening with them exactly, and
Yeah,
so it then
yeah.
becomes a slight problem. So we all have to discuss how we're going to run this, and what happens if they shut us off, and
Protocols.
yeah, exactly.
It's
And
all
to
about
be honest, yeah, yeah,
protocols.
that's one of the biggest things I learned from air ambulance work is protocols, sign
And
off process,
communications.
yeah,
Yeah.
communication skills, and just all this kind of preemptive stuff,
Yeah. And call and
which
response. Yeah.
exactly, and we just try to build it in into our kind of day-to-day
Mm.
trauma management. I think you're right though. Compartments, going back to compartment syndrome, you're totally correct. We need to think about what's the worst case scenario that can happen to this patient. Are they going to bleed a lot post-op in recovery or in the ward? Okay, if that happens, who do we need to check the patient? So that's why specifically for certain cases I will have the on-call senior resident go see the patient. I won't just leave it with the on-call kind of intern or
Sure.
on-call junior resident to see them, and I won't just leave it to the nurses either. I'll have them specifically go check the patient twice overnight, etc., especially if it's a complex pelvic patient that we've just fixed. And then for other cases like, okay, compartment syndrome, if I really think it's a significant risk for one of the patients or whatever, then I'll again have one of the doctors, surgeons go see them properly and really assess, and then get feedback to me as well overnight just to check.
So to continue thinking about residents, you manage the Orthopaedic Trauma Fellowship Program at
Yeah.
King's. How do you prepare the next generation of trainees to handle conditions like we've been discussing? Key skills, knowledge areas to emphasize in training. Training has changed dramatically
Yeah.
from when I trained, and you said even since you've been trained as
Yeah.
a, you've been a consultant for 6 years, right?
Yeah.
I think you said, yeah, yeah.
Yeah.
So yeah, well, what are your thoughts on that?
So when I was in post as a consultant for about 2 years, I think, before I got given the responsibility, or even like 1 year, and then got given the responsibility of the fellowship. And so I run within our department, we're broken up into four different subgroups. So we have like a trauma firm subgroup, and then a upper limb, a lower limb, and then a foot and ankle peds group. So in the trauma group, which I run, that's where all the trauma fellows come. And so we have four trauma fellows who are all post CCT. So they've basically done all of their board level examinations in the UK to become consultants. And they're just doing effectively a fellowship with us prior to then applying to consultant jobs, or before doing a second fellowship in a other specialty like sports med or arthroplasty. So they'll come to us. So I try to learn lessons from people who mentored me, because I've been fortunate in having some great teachers along the way. Pete Bates at Royal London, Chris Moran at Nottingham, David Hahn at Nottingham as well. And then a lot of people, there's be a long list if I start now, and there's half of them will hate me for not
It's
mentioning them.
like giving an Oscar
Yeah,
dedication
yeah,
speech,
exactly.
perhaps.
Anyway, so that I'll just give a few. So I've just tried to copy the bits I found really helpful from them, and in that actually I've then tried to copy bits I've learned from air ambulance service, my air ambulance work. So I made like a sign off kind of section of stuff that I want the incoming fellows to read, to go through our protocols, why we do things a certain way, what the evidence base is behind why we do it, so they get a really deep understanding. I don't necessarily want them finishing the year with us not really understanding that, so I'd rather front load it so they get it out of the way to begin with, and then they can ask questions and then watch it being put to use, and they can implement it themselves when treating patients. And then the other thing is we do a lot of planning. So, like you filing a flight plan before you go from A to B, we will do our surgical planning before we even enter theatre, before we even anesthetize the patient. We would have discussed how we're going to fix something, gone through our different tactics for doing it, have a plan A, B, and C. Maybe you end up doing plan D that we've never thought about, but we go through plan A, B, and C. And then, so hopefully, by the time we actually get into theatre with our patient, it's just execute a plan that we've already spoken about. And what I really try to encourage them is to mentally rehearse the operation in their mind. So when I was a fellow, and even when I started as a consultant, I used to mentally rehearse some of the more complex operations. So literally just imagine myself doing the whole thing start to finish, and obviously accelerated. So I wouldn't be there for 3 hours doing it, but rather for about 5 minutes going through all the steps of what instrument I'd need, how I'd do it, and then if it didn't work, what else would I need? And so that when it then came to executing the plan, it would then hopefully just follow a very kind of seamless course. And I think that's what I'm trying to get them to do. And then I will just help support them as they do the great job that they do.
Hanger flying, we call it in aviation.
Okay, yeah.
Yeah, there you go. The parallels are great. And there's also the other author too, if you've not come across his work, Atul Gawande.
Oh yes, no, no, absolutely.
Yeah, fantastic.
Yeah.
Love it to death. You've done training days for operating theatre, operating room nurses on compartment syndrome and pelvic
Mm,
fractures.
yeah.
My scrub nurse, Linda, if by any chance you're listening, love ya. She was always my aide memoire, as
Mm,
well as possessing many, many other talents. An
yeah.
amazing woman. Tell us how those training days panned out, please.
Yeah, no, absolutely. So the training days are for all of theatre. So it was the scrub staff, but also the recovery staff as well.
Yeah,
And really, it was to explain to them kind of the background of certain injuries, how patients sustain these injuries, why we do the operations that we do, and then the complications like compartment syndrome, so that the recovery staff knew what to look out for in recovery as some of the early signs, issues of bleeding with the pelvic patients, etc. And so and really just to better inform them so they had a much deeper understanding and were able to help the patients through that journey from theatre into recovery and then back to the ward and then handing over to the ward staff. Absolutely, I agree with you. Like the theatre team totally look after surgeons, and I think we have to really look after them as well. As you can imagine, orthopedics is a very very technical specialty, you know, and the scrub nurses. I mean, I spend a lot of days in the week, about 3 days in theatre, so I'm there quite a lot. But the scrub nurses know the kit inside and out, and are always very good with it. And they are super useful, especially for the fellows, and especially for my other colleagues who don't use certain devices all of the time, and they can really talk through that. And I think we obviously in orthopedics have their various company reps also come into theatre. They're not allowed to scrub, obviously, but they're there also to help provide that support because orthopedic kit is only getting more and more technical. And if you're not using it every day, it becomes really difficult to kind of remember exactly how to do various things. It's a great device, for example, is a fibula nail. So it's like a tibial nail, but for the fibula, and it goes backwards in the lateral malleolus up the fibula. So I remember last year I'd done quite a few just because of the way, just because of the random nature of how patients present. I had to do quite a few on the trot, so that's straightforward. And then it was quite a lot of months at the end of last month, and I think only done one this year. And then 2 weeks ago, I had to do three, one on each day. And I remember at the first, I'm thinking, oh, geez. So I was putting the device, the jig, on the nail so we can help put it in. And there's a certain way it has to be mounted, and there's safety mechanisms on the jig to make sure you mount it, but there's still a bit of an error. And thankfully we were putting it together, and the scrub nurse is the one who noticed actually we just need to do a slight adjustment to one of the screw handles to make sure it goes on, because if it doesn't go on the right way, you can put the rod in, but then trying to put the screws into the rod is not going to work, and it becomes a much more painful operation than it needed to be to try and fix it. So it's all these technical things to really really help you out.
yeah. So you've talked a little bit about recovery nurses, operating room nurses. You've talked about your senior residents. Are there other roles of healthcare professionals to ensure optimal patient outcomes and different points of view in
Yeah.
managing trauma?
No, no, absolutely. I think for trauma, there's
The
clearly the
anaesthetist, of course. Yeah,
no anesthesia. I mean, there's a whole load. I mean, I think trauma patients really see the entire gamut of the hospital on their journey, especially the polytrauma patients. So, polytrauma patient will see, the emergency medicine doctors, the emergency medicine nurses, etc., and then they'll go to intensive care where they'll see everyone there, including the intensive care physiotherapists, looking after their respiratory physiology, trying to prevent chest infections. They'll see the surgical teams at various points. And then once they've had everything stabilized, then there is a massive rehabilitation team that needs to help with them
sure,
in the hospital. So that's your physiotherapists, occupational therapists, etc., to mention a few, sometimes speech and language, sometimes neuropsychology and psychological teams for all the kind of more holistic care to really help manage them, because a lot, you can imagine, a lot of these patients have significant psychological issues
sure,
after their injuries, and it's such a common thing. Every patient I see always has some issues pertaining to their original injury of anxiety, depression, difficulties getting back to normal. So there is a huge group of people that treat patients from start to finish. Surgeons such as me fit in a small part in there somewhere. And then, but actually, without the people before and after and even during, the patient's journey would very much be incomplete. So
Very
I think, yeah,
different.
absolutely, it's a
Yeah,
very, very long road to at the end recovery, with a lot of people playing their roles along the way.
yeah. And it's interesting how medicine has matured. I mean, I think in colorectal surgery, what we do when we do a colorectal procedure without the stoma nurse
Yeah,
prepping the
yeah,
patient, we got a nightmare on our hands.
yeah, yeah.
And kudos to you for calling out. I knew you were a nice guy, and you could win an Oscar and do the thank you speech. What haven't I asked you, Ash, that you would really hope I might have asked you, or take home point that you want to deliver to our listeners?
So I think actually I think the take home point is probably the bit I said at the end. Okay, so medicine these days is definitely involves multiple people, multiple roles to help ensure a good outcome for the patient. From our trauma patients from the roadside with the pre-hospital care teams, all the way to the rehabilitation side with the occupational therapists, etc. And all the different teams play a really important role in that patient's recovery. And I think to know how important it is for patients to have the psychological support on top of the hard medicine, like the surgery, the anesthetic, the different bits. There's a lot of holistic care that we need to fix that I don't
Sure.
think any country has really got quite a handle on. But hopefully, over the coming periods, we'll get on that. I mean, at the moment, I'm trying to work on a relationship between one of the air ambulance organizations and one of the hospitals I work at to develop a patient app, but for kind of patients who are treated by their ambulance service to help, again, give them more information, give them a better idea of how things should be going, give them advice about nutrition, about stopping smoking, to say the least, about what they can do to minimize the risk of DVT. So I think all of these things are really important to help improve our end patient outcomes.
Yeah, and as we said, being alert to the complications like compartment syndrome that can happen,
Yeah.
and constantly thinking about how we can improve the quality of care that we deliver, right?
No, no, absolutely. I think for compartment syndrome, you're right. I think in this day and age with technology, the clinical examination, we must be able to do a bit better better than just wiggling the toe passively and seeing if it hurts them or not. Because I'm like always wondering is clearly it's going to hurt you. How much more it's going to hurt you? I don't know how much more that necessarily equates to compartment syndrome or just because I've just done it. And
You
I think,
know,
yeah, I
Ash,
think a more technical way of doing that would be useful.
yeah. So I know I've used a lot of aviation analogies to someone who also shares a
No, not like you
respect.
though. I just sit in the back and get flown.
I love sitting in the front and
Yeah, yeah.
doing the flying.
I've sat
But
in the front once on a training flight. It was great fun.
well, get your license, man. Get your
Ah,
license. Let's go
yeah.
flying together. Get your license. It is. There's a song by Pink Floyd, "Learning to Fly," and every time
Yeah,
I
yeah, yeah, no,
sit at the end of the runway with a ribbon of black in front, I just have this immense sense of awe. It's the most wonderful
Mhm.
sensation. But they say that a good landing is one where you walk away. A
Yeah.
great landing is one where you get to use the aeroplane again. And someone once said to me, and I've been flying for very many years, someone once said to me, how do you know when you've made a really great landing? And I said, well, when I've made one, I'll tell you, because
Okay.
you can always do
Yeah,
better. You
yeah.
can always, always, always do better. And there's some element of, yeah, I need to improve this. Sadly, we're out of time, so it just remains for me to thank Mr. Ash Vasireddy for joining us today, for sharing his work and all he's done, and I know will continue to do for patients. Real joy talking to you, Ash. We need to get together for an adult beverage at some point,
Yeah, absolutely.
and a bit
John,
of
thank you
world
so much.
fusion,
Yeah, no,
fusion
no,
cooking.
absolutely.
That'll
Yeah,
be a joy.
absolutely. Thank you
Thanks.
very much.
So, and to our audience, thanks so much for taking the time out of your busy day to listen and demonstrate a desire to see the best care for your patients. After all, we're all going to be patients sooner or later. Please share this with your colleagues, post on social media, write to us with comments, suggestions, questions, anything like that for other podcasts you want to hear us do at underpressure at nextsense.com. That's underpressure at nxtsens.com. Thanks also to Maya One for supporting this podcast. So that basically all that remains for me to do is say thank you. I'm Dr. Jonathan Sacchi. I'm proud to be your host and Under Pressure. Please, everyone, stay safe, stay well. Stay curious. Bye for now.